I think we can go on.
Yeah, once it is done there.
We are live now, doctor.
Hello and welcome everyone for this live webinar by Glaucoma Society of India. And I'm Dr. Satyan here. We have three speakers for the day. The masterclass, Dr. Rajul Parikh, Dr. Ronit George, and Dr. George Putran. We have selected the topics in such a way that it really helps the practice of glaucoma. It is all very practical topics we have selected in all these past 6 days. And today also we have selected very important topics for our practice pattern. Very important topics. The first talk is going to be by Dr. Ronit George. He doesn't need any introduction. All the three speakers doesn't need any introduction. Without wasting time, I'm going to request Dr. Roni to talk on his topic. Over to you, Dr. Roni.
Thank you, Satyan, and thanks Satyan, Manish, Deven, and the Glaucoma Society for the opportunity to speak here. So, I'm going to speak to you about predictive clinical markers for visual field progression. So, glaucoma is by definition a progressive disease, and what's very important for us in our practice when we are treating glaucoma patients is to actually assess what are the patients at greatest risk of progression. And the information for this actually comes from prospective interventional studies where something has been done to see what happens to a patient, risk factors from large clinical databases, and I'll also talk about a few clinical correlations as we go forward. So what do you need in order to be able to assess a risk factor for progression? You actually require large patient cohorts who have been tested adequately, because that's the only way you'll be able to pick up visual field progression with longitudinal testing. Fortunately, when you look at the glaucoma continuum, we have got undetectable disease, asymptomatic disease, and functional impairment broadly categorized. And we have studies in all these areas where you can detect some amount of progression. And there are a number of randomized controlled trials on progression which have looked at treatment versus non-treatment for ocular hypertension to POAG progression treated versus untreated, and POAG progression using different treatment algorithms. And we have information on visual field progression from all these. So the advantages of the randomized controlled trials are that they're well documented, there are well-defined endpoints, and structure and function are both available. But of course, today we're going to speak mostly about functional changes. The disadvantage is that they very often have very limited severity of disease at baseline. They have limited follow-up. They have restricted treatment options, and they have all POG and TG spectrum. And a multitude of progression algorithms have been used by all these things. So I'm also going to include some clinical data sets to talk to you about the risk factors for progression. These are the RCTs which I'll speak to you about. I will not really include the CNTAGs today. I'm also going to talk to you about a couple of clinical cohorts. One of them is an Indian cohort where we looked at about 9,000 patients with 5 or more visual fields to see how they progress. And one of the interesting things that we found along with my collaborator, Georgian, was that when we looked at our data set and we applied different visual field progression techniques that have been used in AGES, CGITS, GPA1, GPA trend, what you can see in this plot here is those black markers basically show you when two different types of visual progression biomarkers algorithms match. You can see that this is quite, they don't agree with each other most of the time. So a lot of these places where you're seeing one or two different algorithms agree with each other. That's why I'm going to talk about each algorithm separately to see whether they actually agree with each other when it comes to risk factors at least. So the OATS and the EGPS looked at progression from ocular hypertension to glaucoma. And these were the risk factors that they found for primary or primary glaucoma. Older age, higher intraocular pressure, lower CCT, worse PSD, and a higher cup-to-disc ratio. And these are the studies that all of you are, graphs that all of you are familiar with, that intraocular pressure, low intraocular pressure, and low CCT was the greatest risk factor for progression in both the ocular hypertension treatment study and the European glaucoma prevention study. So this gives us some insights onto the risk factors for progression in ocular hypertension. When you look at the collaborative initial glaucoma treatment study, And these were the baseline factors. So if you had a follow-up time, a longer follow-up time, you were more likely to follow to have progression. That is, of course, logical. If you were older, you had 35% greater risk of progression for every 10 years of age. If the range of your baseline intraocular pressures was more than 8.5 millimeters of mercury, you were almost 2 times more likely to progress. And this is the advanced glaucoma intervention study. And here again, you see that if your average intraocular pressure over the first 3 months was less than 14 millimeters of mercury, you were unlikely to progress. But if your average intraocular pressure over the entire time was less than 12, you were unlikely to progress. So higher intraocular pressure was definitely a risk factor. The UK glaucoma treatment study is actually a little different from the other studies. Most of the other studies used fixed testing. Every 6 months or every 1 year, they would test to see what happened for progression. But when we look at the UK glaucoma treatment study, they did this a little bit more smartly. They did multiple tests at each visit. So visual fields, 2 visual fields, 2 months prior to recruitment, at recruitment, and 2 months after recruitment. And then again, at about 18 months, they did 6 visual fields bunched together. And at 24 months, they did 2 visual fields. And there just lots of OCTs in addition to this. So the advantage of this was they were trying to pick up progression much faster with much more intensive testing. And what they found also was with much shorter follow-up, they found that if you had bilateral disease, you were 60% more likely to get worse. If your baseline intraocular pressure was a little higher, for every millimeter increase in pressure, you had a 7% increase in risk of progression. If you had a disc hemorrhage at presentation, you were twice more likely to show progression. And surprisingly, if you had ever smoked, you were less likely to progress. But this is actually, this is highly selected data, so the last probably does not carry any weight. When you looked at the early manifest glaucoma study, here too, bilateral disease was associated with almost 2 times greater risk of progression. An intraocular pressure of more than 21 was associated with a greater risk of progression. Pseudoexfoliation was associated with a 2.2 times greater risk of progression. A worse baseline MD or an older age was associated with a greater risk of progression. So this is also fairly consistent with the collaborative initial glaucoma study. And they also found that the intraocular pressure, the first follow-up visit over the first 3 months, higher intraocular pressure was associated with 11% greater risk of progression, and the mean intraocular pressure across all follow-ups was associated with 13% greater risk of progression. This is per millimeters of mercury. So essentially, if you get your pressures lower, the risk of progression is lower. So when you look at intraocular pressure as a risk factor for progression, what you see here is that higher baseline intraocular pressure was seen by the OATS, the EGPS, the EMGT, and the UKGTS. In every study, if you had a higher pressure to start with, you were more likely to progress. If you had more fluctuation at the baseline, the CGITS group did progress. If you had higher IOP on follow-up, EMGT and UKGTS both showed follow-ups, showed progression. And if you had higher fluctuation during early or higher IOP on all follow-ups, the ages found that you actually got worse. So this is a young POG suspect with a family history of glaucoma, and what you can see there is basically a little bit of thinning of the inferior rim with a nerve fiber layer defect. Visual fields looking fairly normal. The OCTs start to show a little bit of change there. As you go over time, especially with the GCC, you see some change there. But when you look at his untreated intraocular pressures over time, what you're finding is a fairly large range, 12 to 22 millimeters of mercury. So this is a classic clinical example of somebody, even though the baseline IOPs were good, they had a lot of fluctuation over time, and this is probably the reason for progression. We look at older age as a risk factor, and when you look at older age as a risk factor, except for the UKGTS, all the other studies found that older age was a risk factor. The UKGTS probably did not find this because they had fairly short follow-up. So the older age is a double-edged sword because the older you are, there is a greater risk of progression. But the younger age that you are at diagnosis means your lifetime risk of progression is greater. And this is something that we should keep in mind when we're assessing risk for progression. And when we looked at our own cohort some years back, we also found that our youngest age group, if they continue to progress at the rate that we saw in the clinic, they were much more likely to go blind as compared to those with PO aging. Pseudoexfoliation was excluded in some studies, but it was there in the EMGT, and pseudoexfoliation on its own was one of the highest risk factors for progression. And here I'm going to share this example of a 45-year-old cardiologist who, this is what his baseline fields look like. This is 18 years later. One eye has pseudoexfoliation, other eyes did not have pseudoexfoliation, and look at how the visual fields have progressed. So pseudoexfoliation is something which is a red flag. We should look very carefully for progression in these eyes. And if you look at his intraocular pressure over time, you can see that his intraocular pressure, which was doing fairly reasonably well, spiked to the high 30s and required many additional medications to get him under control. And that's when his visual field went from scattered inferior defects to a biarcuate defect. Disc hemorrhages were independent risk factors of progression in the ocular hypertension treatment study, in the EMGT and the UK GTS. In fact, if you had the disc hemorrhage at presentation in the UK GTS, you are 2 times more likely to progress. And when you look at the percentage of visits with disc hemorrhages, as in the EMGT study, the risk of progression is about 2% higher. So they're slightly contradictory there, but this percentage of disc hemorrhages was a risk factor for progression. This is another study which looked at the ocular hypertension follow-up over 13 years. And what they found was that if you had no disc hemorrhages prior to converting to POAG, you had a 10% risk of conversion. If you had one disc hemorrhage prior to becoming POAG, as defined in the odds, you had a 19% risk of progression. And that continued to increase. If you had 2 or 3 disc hemorrhages, your risk of progression went up to 23 or 40%. And that's fairly significant because it tells you that disc hemorrhages are a very important clinical marker for future progression of visual fields. The EMGT also reported that lower perfusion pressures were a risk factor and this sort of fits into the disc hemorrhage part of the story also. And I'm going to share this with you, this 25-year-old who went incidental HRT evaluation. We saw a disc hemorrhage there, and we are wondering why. And then when we take a history, we found that she had a history of mitral valve collapse. She had been on systemic beta blockers for 2 months. Her blood pressure was 90/60, and this caused reduced optic nerve perfusion. And we thought, yes, that's the reason that she had a disc infarct, and that's the reason that this happened. And this is what happened to her disc over time. 12 years later, you can see a visual field defect there in the right eye, and you can see a visual field defect in the left eye. And the left eye never had a disc hemorrhage or anything at baseline. So this is somebody who basically, because of low perfusion pressure, is showing an NTG type of picture. I'm also going to end with a few large clinical data sets. So I'm going to show you 4 large clinical data sets, one of about 2,000 patients, one 4,000 patients, one 6,000 patients, and one of ours, which is about 8,000 patients. And when you look at the risk factors in these large clinical data sets, you find that higher intraocular pressure was a risk factor for Chauhan et al. For both Kirwan and for our data set, older age at baseline worse MD at baseline was a risk factor. For Jamal et al., both the visual fields and the SDOCT worse parameters at baseline were risk factors for progression. We also found that if you are older, you are more likely to progress. So to summarize, what are the predictive risk markers that we know? Older age at diagnosis. Definitely, if you are younger, you should keep in mind that they're at lower risk of progression, but the lifetime risk of progression is high. If you have worse disease at baseline, if you have bilateral disease, if you have pseudoexfoliation, if you have disc hemorrhages, reduced perfusion pressure, these are all risk factors. Low CCT in the presence of high IOP in ocular hypertensives is an independent risk factor for progression. Thank you.
Thank you, Ronnie, for the wonderful talk. And it is such an important risk factor that we need to assess. But unfortunately, many of us, we really may not be doing the visual fields in the ideal time points, as we have seen in most of the studies that the ideal thing is to do 6 visual fields in the first 2 years to understand how the field progression happens. Either they are the slow progressors or they have the fast progressors. In an ideal clinical situation, that is the ideal thing. But unfortunately, we really may not be able to do that. But in your clinical practice, and others also, of course, they can contribute. Do you really do that to understand is that they have a slow or fast progressors?
Satyan, I do try to do it. Actually, what happens the first time I see a patient and I diagnose a glaucoma, I tell them that this is what the plan is, and this is the reason that we need to do the test. And I find that a lot of patients, once you explain to them at the first time, they do actually come and do the test.
Right.
Because if you do it, if you tell them when they come every visit, they wonder why it's happening. But if you tell them right at the baseline that this is the plan for the next 2 years, it sort of helps. And I think maybe 3/4 of my patients do actually agree to get it done.
Like you do 6 visual fields in the first couple of years?
Yes. So I typically do the field at the first visit, and then maybe at 1.5 months or at 3 months. And then after that, 6 months after that, 3 more. So in the first year, I'll probably get three fields or 4 fields, and the last 2 in the last.
Okay, so this is the kind of an idea that we need to understand. It is for all the people whoever is listening to and who will be listening to the later one. So it is how you talk to the patient to make them understand. The thought process is always we feel that our patients will not be doing when we advise them to do so. But it is how you really talk to them and explain them what is that you're really looking for. So when Roni is able to, convince the patient for first 2 years, 6 visual fields, I think we should be able to do that. And thank you so much, Rani, for that very important tip on how to do the counseling to start with, to do the visual fields. We will have a lot of questions. We'll have the talks and then we'll have the question session later. Rajul, are you ready?
Yeah, I will. Should be ready. So,
Yeah.
okay.
It is still showing has started screen sharing, but
No?
we are not seeing the screen yet. Just wait for a few seconds. Because when you opened last time also it took some time. Would you like to retry one more?
Yeah, I.
Just stop sharing and then you can retry one more time.
Yeah.
So just
Now?
stop,
No.
stop screening and then you can come again, Rajul.
Yes.
You're still showing that you are.
Yeah. So I stopped. Now let's share again. Entire screen.
Yes. Now we are able to see the.
Oh no.
No, you're not.
Now we are able to see, but it is yeah. Now it is the first slide is up.
Yes, no?
Yeah, the first slide has come. We can hear you and we can see your slide. You can go ahead with your talk.
Okay. So, so is moving slides.
Yeah. Yes, Rajul. Go ahead.
So, yeah, I'll be talking about rethinking first-line glaucoma therapy. I would like to thank GSI for this talk. So, I'll be talking about drops versus SLT versus mix as a first-line option, and the main. So, Satyan, you can see the slides, no?
Yes, we can see, we can hear you well.
So the bottom line is that the first line option is not the most familiar option what we know, but it is the most likely the option we should choose. It is most likely to deliver the substantial target IOP control with least dependence on the fragile long-term behavior of the medicine, surgery, drugs, and patient behavior. So the objective of this talk is basically I try to review the randomized trial related to the medicines, lasers, and emics. We'll try to highlight some real world problems and translate these RCTs into the simple clinic ready decision algorithm. The burden of glaucoma, we all know, I'm not going to go in detail. the only one thing we must remember, that the vision loss is irreversible, and most of the time patients do not realize the vision loss in early stage of the disease. So delay, under treatment, non-adherence, they are very important in like all the chronic disease, but glaucoma is more important because of the irreversible blindness it causes. So why the first decision is first stage, what you choose is very important. Again, the glaucoma is asymptomatic. The initial treatment basically becomes the long term pathway. Then the cost is involved, whatever we choose. The strong first line strategy should be the effective, and the first line also, because the patient would correlate his problem with the first line treatment. So whatever you choose, his problem with the medication or failure of the surgery, whatever, so the first line treatment should be the effective, sustainable, safe and realistic in the patient's life from the doctor's perspective as well as from the patient perspective. Now I'll just give one example. 50 diagnosed with POAG, 26 pressure, early nasal step, and correlating inferior RNFL thinning. This is the classic routine decision, case where we do not think about it, we just start the treatment. And if you had asked me a decade back, I would have, without hesitating, would have said that I would start with medical management, preferably prostaglandin. But now, the question we are asking, that what options we have, and why? Because now it is time tested. We have SLT, and SLT of course is there for long time, but after light study, the way we are looking SLT effectiveness has changed, and we have mix. So there are three options, and I will be trying to justify pros and cons of the three options, and then I will tell what I would like to do or I do in my routine practice. The first is medical therapy. So we have prostaglandin, beta blocker, CA inhibitors, alpha 2 agonist, ROCK inhibitor, fixed combinations, and we know that prostaglandin is the most effective as a first line therapy, and we have other options also. And we know from various studies that fixed combination is better because it reduces the burden, reduces the load of preservative, so it improves the compliance because it is more convenient from the patient perspective. So I can talk about various RCTs. I'm not going to talk. I just listed few. I'm not even bothered to go in details. But we know that most of the RCT medication works very well. And if you look the UKGTS, where it shows that the drug therapy can preserve visual field, the progression reduces when we start medical therapy. And CIGTS. And why I kept CIGTS? CIGTS was drug versus surgery, but they had target IOP calculation for every patient. And if the target IOP is achieved with the medication, then the visual field progression is more or less similar in the medication group also. So it's a very strong contender that medication first is good, because if you achieve target IOP, then the patient can have a as low visual field progression like surgery. But every pros has a cons also. It's like a two side of the coin. So when I talk about medication we have to understand that they are not biologically neutral, they are preservative. Of course now they are preservative free medications also available, but drug inherently also can have side effects. The preservative causes ocular surface disorder, inflammation, and if the patient develop conjunctival inflammation in long term, the success of glaucoma filtration surgery, especially incisional surgery like trabeculectomy, reduces drastically. And we have to keep this in mind because significant number of patients who may require surgery in the future. Second most important, in any chronic therapy, adherence is the major problem. And if you look the studies, then non-adherence is range between 30 to 80%. It all depends how the adherence was measured and how it was defined. But studies have shown that the lower adherence is linked with the higher IOP and more faster progression. So if you look few studies, it's written that if the adherence is less than 80%, then visual field progression is very faster. Now adherence is there are many factors, and I'm not going to talk about it. It leads from the forgetfulness or too many drops or the lack of knowledge about the disease, or their skepticism about the medication or about disease, various factors. So adherence is a big issue when it comes to the drug medical therapy. And it is well established that forget glaucoma, even if the disease where the mortality is there at the end point, even for those diseases the adherence is poor. Now adherence is one issue. Other issue is because we every time patient has to put the drops. So patient can be adherent, but if the drops are not going properly in the eye, and if you look, and in fact not even look, if you just check 10 patients in your OPD, ask them to put the drops, you will realize that significant percent of the patient, especially in the older age group, beyond the 60, the way they put the drops is incorrect. So they are putting the drop. They are very adherent to your instructions, but the drops are not going in the eye, so end result is zero. So the bottom line is, if you have something which removes the need for this daily administration, it would be very good, because it would take the adherence out of your equation. So that is something against we have to think about the medications. So in medical therapy, basically the behavior limits the therapy, the how patient think about the disease and how patient follows your instruction. That is about the drugs. The second is SLT. Now I'm not going to talk about how SLT works and what are the pros and cons and the side effects. That is not the part of the talk, but the light studies. So SLT was there for 2 decades or more, but we were not using SLT as routinely. Of course, some of us were recommending, I was not one of them. But the light study definitely changed the scenario. So light study had a very simple question that in early glaucoma, especially treatment naive, whether SLT should be tried as a first line or not. And light study showed that at the end of 3 years, nearly 74% of the patients were medication free and they didn't need surgery. The eyes with SLT first time where the target IOP was more than 90%. Of course, quality of life was better because of the less need for the medication. And when they extended to 6 years, still, of course, the need for the medication increased, but still nearly 69% were medication free. So if you look, the 6 year, the disease progression is less in SLT first term, the need for glaucoma surgery is less, and need for cataract surgery was less. Now this is of course the secondary outcome, but if you look EMGT also had more cataract in the medication arm, and the lights also showed that the cataract surgery is more required in the medication arm. So maybe the drugs are one of the risk factor which increases the faster cataract progression. Maybe I'm not going to talk about it, but we have to keep as one of the factor. So what light means in the clinical study, that SLT is not longer a backup option, but we should consider as a first line, especially following the light protocol, that mild to moderate or ocular hypertension and treatment naive. So those eyes were treatment naive, and that we must remember the treatment naive eyes. So they were the first time the laser was done and where the SLT works really well. So they are the ideal candidate. So, but again, pros and cons, the other side of the coin. If you look as the disease, if you have moderate disease, advanced disease, the glaucoma, the SLT success rate is less. The advanced disease, moderate disease, even SLT works, the need for drops will not reduce. You will have to have more than one drops. If the baseline IOP is less, then the IOP reduction with SLT is less. So if the IOP is more than 24 at baseline, the SLT works much more. Then effect of prior medication, and this way I said that the light study had treatment naive eye. But if your patient already on medication, then the SLT success rate is poor. There are various studies have shown that. So key important finding, if the baseline IOP is high, if the patient is treatment naive, and if the disease is early, mild, moderate, then we can consider SLT as a first line of treatment. This is my message from SLT. Now, I like clinical epidemiology, and this is not very important, but it gives some extra benefit. So if you have the basically compared to the drops, if you do 50 SLT, you have one less progression. If you do 33 SLT, if you have one patient needing less glaucoma surgery. Now these numbers are not very significant, but POAG patients or PSCG, but I am talking about POAG, they would require some line of treatment, either medication or SLT or surgery. So if you do SLT, the need for glaucoma surgery reduces for first 6 years. So this is the extra benefit of the SLT. So, and caveat, of course, you must remember that they are not as drug free. So should not over promise the patient will be drug free, because more than 30% patient in first 3 years would require some amount of medication. And you have to remember that all what I am talking about is in relation to the light protocol, early to mild to moderate POAG, ocular hypertension, and most importantly treatment naive patient. So SLT reduces the dependency on the drop. That is the message. It doesn't reduces the need for medication, but it is a very good choice as a first line. Third is mix. Now mix again is the bucket of procedure. Mix is not one procedure. It's conjunctiva based, canal based, supraciliaris based. So again, I'm not going to talk about the mix per se. What are the procedures? But mix as the first line. Now mix as first line in POAG. The debate doesn't arises because if you look the literature, the mix always has a good success rate when it's done with the cataract surgery. Most of the early glaucoma, most of the time, would be in 40s or early 50 where cataract is not there. So mix I would not offer as a first line unless patient has come with a significant visually significant cataract and as POAG where I planning cataract surgery, I would do mix. That's a different issue. So here the debate ends as far as the mix is concerned, but I will go on and talk little bit few the horizon study. And why I am talking about this, that if patient has visually significant cataract, what sort of devices we can consider. So we have goniotomy, ab internal goniotomy with cowl blade. We have hydrus turned eye stand. The hydrus had a success rate of nearly, when done with the cataract, nearly 66% were the medication free as opposed to 46% with the cataract surgery. The medication burden reduced from 0.5 to 1 when we done only with the cataract surgery. The need for incision surgery reduced to 2.4% versus 6% in only cataract surgery. And the same result I stand, but when you compare the hydrus as a more IOP reduction as opposed to other devices, and again I know personal interest because hydrus is another limitation of the cost, especially the India is concerned. Now this is the data, only phaco, mix, and when you combine. So when you combine only the IOP reduction is substantial. So mix, we have to remember that we are talking only with the cataract surgery. Again, there are multiple procedures involved mix, and every procedure IOP reductions. So but mix is a pressure optimizing strategy and should be considered as first and if the patient has significant cataract, otherwise I would not consider. So this is just extrapolation, actually little bit beyond the data because I have taken various studies, but drops in SLT have a very similar IOP reduction. Mix along with the cataract surgery also has a little bit less IOP reduction, 1.2 millimeter. It's not much. This is the graph shows significantly more, but is around 1.2 millimeter. So what I would consider as a practical algorithm, newly diagnosed ocular hypertension, which of course every patient we would assess its severity, we would assess the target pressure, adherence, risk factor, affordability, but mild early disease, young patient, if the patient adherence can be an issue or patient is treatment naive, I will consider SLT as the first option. Of course, if you do not have the SLT option available with you, please continue medical therapy. I am not against medicine, but it do have an advantage that it takes care of the adherence for time being. If the patient is mild or patient is more than one medication already and our target IOP is achieved, then I would continue medication. I would not try SLT. Of course, some people can consider, and that also is an acceptable option. If the patient has visually significant cataract with mild to moderate POG, I would consider cataract surgery with the mix, and there are various options available. I am not going to talk about it. If the patient is moderate to severe or patient requires low target IOP, I would start with medication and consider incision surgery like TRAP or AGV, preferably mostly TRAP. So this is how my graph works. Mild to moderate, young patient, SLT, I would offer as a first line or medication. Visually significant cataract, mild moderate POAG, phaco with mix. Advanced, I would continue drops plus minus trabeculectomy tube as and when required. So back to the first case, as I mentioned, a decade back I would have considered drops only, but now we have an option of SLT, and I would consider very strongly because this is a classic patient, follows all the criteria of light study, and we can consider SLT. So and the drop works. I have nothing against drop. In fact, drops we are using for decades, but it's just that adherence is a big issue, and the light study showed that SLT is a good option. So my for early POAG treatment naive patient, my debate would be versus drop and SLT. I may favor for SLT if patient understand the pros and cons and the follow up and may need medication, and mix only when I am planning cataract surgery. To end, first line therapy is a decision, is not a habit, is not a slogan, is a clinical strategy. So we follow, go through the complete examination, discuss with the patient and find the strategy. And the best strategy is which the patient and doctor both understands. Thank you.
Thank you so much, Rajul. Yeah, wonderful talk. And I think it's very, very yeah, practical talk for most of us to take home some message. So I think all the three are there in our kitty. It's when the patient comes, it is how you can make the right decision for the patient. We'll have more discussions, Rajul. We'll go to the next topic and then we'll have discussion. Raj, are you there?
Yeah, I'm here, sir. I'm here.
Yeah. Please. Yeah, we can see your slides, George.
Yeah.
Yeah.
So good evening, and thank you very much to Glaucoma Society of India and to my president for this opportunity. So I have no financial interest to disclose. So I always used to wonder why, as glaucoma surgeons, if we are proficient enough to do a good trabeculectomy, why not all of us can do a good tube also? So it's basically the safety profile of the surgery that is a hindrance for many of us. So I thought I will cover hypotony, tube blockage, tube exposure, and if time permits, very briefly about retraction and corneal complications due to tube. So hypotony can be very early. So it is essential that we avoid peritubular leakage, whether it's a valved implant or a non-valved implant, where your tube has to be a snug fit in the scleral tract. So here is a patient who had an AGV. Even after 72 hours, the AC was not forming. When we explored, we saw that the track is very superficial, and also the surgeon has tried suturing either side of the track. So this means the chamber was not forming on table, and just like your trabeculectomy, unless your chamber forms well at the end of the surgery, it's not going to form post-operatively. So we had to reposition. Actually, the surgeon also had placed a scleral patch graft over this, but you should understand that a scleral patch graft over a scleral flap of the trabeculectomy is a little different from a scleral patch graft you place over the tube, where the tube is slightly lifted up and the patch doesn't rest completely flat on the sclera. So another reason for early post-op hypotony is you don't achieve complete watertight occlusion in your non-valved implants during surgery. Hypotony at the time of ligature suturitis was a major issue when we started doing non-valved implants about 15 years back. And hypotony per se was okay. We found that the chambers were forming after about 24 to 48 hours. Fibrin was resolving, but the problem was in high-risk aphakic post-vitrectomized eye, where there was almost near glaucomatous optic atrophy. We even faced suprachoroidal hemorrhage at the time of ligature suture lysis. So now it is imperative that any non-valved implant you're using should get either a 3-0 multifilament nylon or a 4-0 Prolene suture as an intraluminal stent. Another thing we are very worried is the late post-op hypotony, especially in the non-valve device. Both the randomized control trials, the ABC as well as the Ahmed versus Barwell, showed that chronic hypotony was a major issue and was vision or sight threatening when compared to valve device. So till 5 years, this non-valve device used to stay absolutely perfect. One fine day, it starts having hypotony. And it's important to recognize that corneal complications can occur due to hypotony, and you should be able to differentiate it from the corneal complications that occur due to the tube corneal touch or tube induced corneal complication. And it's important to intervene early. Once you see a hypotony, you have the patient complaining of defective vision, and this is a very easy thing to do. You can have your 3-0 multifilament supralon suture. You can just insert it into the tube through the ab interno approach. And this reverses the hypotony to a large extent. But it's very, very important to recognize this complication early and intervene early. In fact, we lost a couple of eyes with chronic hypotony in the initial period. Also, it's important that you should use a multifilament 3-0 nylon. When we did not have this multifilament, we used a 3-0 nylon. And after 3 days post-operatively, the nylon was lying in the anterior chamber. Coming to tube blockage, blood can block tubes in the early post-operative period, especially common in NVG and with sulcus placement, but blood and fibrin almost always resolve spontaneously. The problem occurs when you have a tube iris block like this. The first picture, you can see that the tube has slipped into the surgical PI site and it's blocked. So you will have to sweep the iris away from the tube. Also, you need to trim the tube so that this tube iris block doesn't recur. Sometimes a sulcus placed NVG tube can retract and cause sudden high pressures. Again, a sphincterectomy or a surgical iridectomy will be required. So it's important to have your tube bevel down in the sulcus, which can really reduce the incidence of tube iris block. And one way to do it is, it's not very easy to get your bevel down. You need to enter the scleral groove bevel down to get your tube in the sulcus bevel down. Tube blockage with vitreous, nowadays we just give it to our vitreoretinal surgeon. They do a beautiful job, completely clear the vitreous away. You should also know that for a pars planar tube insertion, you should have a complete vitrectomy, including a clearing of the vitreous base. Otherwise, some kind of vitreous strands can come, block your tube, and the tube function can get compromised. This becomes a little tricky. Tube blockage with silicone oil, even inferior tubes can get blocked. What we do now is, if we prefer the supratemporal superior quadrant, and we try to leave a longer tube in the AC flat on the iris. And if you see, there is silicone oil around the tube. If you put a slit on the tube, you see a very clear area in the lumen. So this is important, especially to exclude tube blockage as a cause for increased pressure post-operatively. If you look at this is a very clear zone. Here you have silicone oil, here you have vitreous, and sometimes vitreous blocking the tube can be very, very subtle. Again, we find that tubes are better than a valve in an eye with residual emulsified oil. We see oil getting washed away very well with the tube. Sometimes tube blockage is not amenable to surgical intervention. Like, we don't know, sometimes we see these kind of pictures, some kind of fibrous growth or inflammatory membrane, and here we have no other option but to repeat the tube. One important tip that we found on the way was, while doing cataract surgery in a post-tube eye, if you insert an iris retractor into the tube lumen, first thing is your chamber stability is better. Second thing is you don't have fine nuclear material or lens material getting into the tube and obstructing the tube. Coming to tube exposures, most often times occur within 4 millimeter from the limbus. So one immediate thing you can do is you can bury the tube for 4 millimeters at the limbus in a patient's own sclera. And this works very well to decrease the incidence of tube exposures, especially in children. And these tubes which are inserted into the anterior chamber close to limbus are more prone for exposure. This is a tube which had a mild exposure. We explored it and found that it's very close to the limbus, and then we had to reposition it to a different site through a 4 millimeter scleral track. The caveat here is you need to bury the tube in a track of adequate length and depth so that the tube completely remains buried in the patient's own sclera. Repair of tube exposures. Tube exposures can occur in two ways. One, it can erode through the conjunctival, erode through the patch graft and through the conjunctiva. Again, the key is reposition tubes to a different site in the anterior chamber. This was another posterior tube exposure. Here, the primary pathology was conjunctival retraction. So initially, the surgeon tried bringing the conjunctiva back, reapproximating it. Again, it went back. Second time, they kept a new patch graft. They put amniotic membrane and again reapproximated. Again, it retracted. So finally, when we repositioned the tube to a different site, again at 15 days, the conjunctiva is retracted, but thankfully, the tube stays there. Nicely buried in the sclera and covered by conjunctiva. And over a period of time, we were able to salvage this site. So at the cost of repetition, repositioning tubes to a different site in the anterior chamber is extremely important in tube exposures. So I have a small edited video here, just describing some of the principles that need to be followed to repair a tube exposure. So again, this was repeat to recurrent exposure. First time the surgeon the conjunctiva was retracted. Surgeon approximated it. and put a fresh patch graft. But again, another 1 month later, the same. So the same mechanical forces that has caused the tube to expose in the first place is going to cause the tube to expose again. So after undermining this conjunctiva well, so once we separate the adhesions between the fibrous capsule around the plate, around the tube and the conjunctiva, uh, you can see that now you can nicely oppose the conjunctiva back. So the general tendency for us is now to keep a patch graft. See this conjunctiva, it just goes back so, but it doesn't, unfortunately, it doesn't work that way. So you need to make a new scleral track with the first tube in place so that your anterior chamber is well formed while fashioning the scleral track. So it's important that you don't extend that scleral track. Another important thing to do is you place a X suture there. You pre-place an X suture over the initial tube entry site, because sometimes after you remove the tube from the anterior chamber, it becomes a little tricky to close this wound. So once you place an X suture and then you remove the tube, and before you do anything else, this is closed. And the tube is now routed through the new scleral track into the anterior chamber. And it's also important in certain resurgeries to ligate the tube once again, just in case you have touched the fibrous capsule surrounding the plate. Coming to the corneal edema after GDD, we were surprised to see that at the end of 5 years, 11% of our eyes in our cohort of patients who received the RD had some form of corneal endothelial decompensation or corneal edema. So it's always important to maximize the distance from endothelium, and this rule has to be obeyed right from the entry into the anterior chamber. In fact, the tube touching the iris has probably the maximum chance of long-term corneal survival. You just cannot afford to leave tubes close to the endothelium. And there are two things here. One is tubes entering the anterior chamber sufficiently away from the endothelium, especially in pediatric eyes, and which then take a route to the cornea, can be very easily trimmed. But if the entry site is very close to the endothelium, right from the entry site, you will have to reposition the tube to a different site in the anterior chamber. Coming to the last part, tube retractions is a very difficult to manage. And in our cohort of pediatric childhood glaucoma, we found tube retractions were the most common complications, to the extent that we have advised to leave a slightly longer, that's about 2.5 to 3 millimeter tube in the AC. And nowadays, for the very young, we even prefer to leave another 2 millimeter outside the scleral track, just in case we encounter tube retractions in these young children, and we can push these tubes into the anterior chamber. So some superior nasal quadrant is preferred location if a tube is retracted and which cannot be salvaged. Not all battles can be won, but I feel it should not be for want of science, knowledge, art, and a bit of perseverance. Thank you very much.
Thank you so much, George, for wonderful slides and good videos and some useful practical points. Though many people are not doing the tubes, but I still feel those whoever has been doing, and I'm sure that whoever has done the tubes, we all have come across this very common problem. And then it's quite interesting to see that, and very small things which can really help these patients, like we can save those patients' vision. Just like, okay, you have a hypertonia, just leave it like that, and then it goes for some kind of a thesical or corneal complications. So instead, if you just can put the stenting the tube by the 3-0, then things can be taken care. So very well done, George. And I would like to sincerely thank all the three speakers, the masterclass speakers, Dr. Roni, Dr. Rajul, and Dr. George. Now we have probably 10 minutes of discussion. Manish or any of our GSI members there, journal members. So you can have your questions first, and then we'll
I have a question for Dr. George. Hello?
Yeah, I'm here. I'm here.
Yeah, hi, hi. So you have spoken about tube exposures, the tube. But what if the plate? Now, about 10 days ago, I had a plate exposure. So how do you tackle that? I mean, tube you can reposition. So I actually then explanted. I tried covering it 3 times, amniotic membrane, but nothing really worked. So 3 times after doing it, I had to explant it and put it in another. The whole assembly. I mean, I had to put it in another direction. So, are there any tips for that?
Dr. Preeti, it's very, very simple. The traditional teaching is once tubes expose, you can try repositioning. Once you see a plate exposing, it cannot, most oftentimes it cannot be repaired. You just have to explant it. There's
Yes.
absolutely.
That's what I learned after doing it. I tried amniotic membrane, tried repositioning the conjunctiva. It got exposed again. So, thank you so much. Ultimately, I had to do that, remove it.
earlier is very important tip again. Earlier, when we had the tube exposures, we used to put again a patch graft and everything in the same place. But the important point here is we should not do that. Again, it will get exposed automatically. We have to take it out and then position it in a different place and then close it. That is the way that probably we can save rather than just trying to close it with some more conjunctiva or a patch graft. Is that right?
Absolutely. I don't disagree with the president.
Because there is a practical point that which I have learned after trying out few cases of that way. It doesn't work. So, Manish, do you have some questions for Rajul as well as for Ronnie? Because those two also quite an important topics, practical topic for practical day-to-day practice.
So my question is to
Manish,
Ronnie,
Ravindra, all of you
after
there?
his evaluation of all the various factors which we can, identify early on the patient, and then we say that this patient has got a higher risk for progression. So does that indicate that we should aim for lower target pressures? Is that is a common sense thing, but that would be the thing to do, isn't it?
Yeah.
Or does it mean that we try to do trabeculectomies earlier in those patients?
I think it's just there are two things I would think. One is that your follow-up protocol may need to be a little tighter. In the sense, you may need to call them a little bit more frequently, you may need to test them a little bit more frequently because that's where you'll pick up progression. And somebody like a pseudo exfoliation, you're going to see more fluctuation. So patients with greater fluctuation, you try and tighten the fluctuation using medications or maybe add on an SLT or even consider surgery. But otherwise, it's just tighter follow-up which helps. So basically, somebody with bilateral disease plus MD, these are traditionally the things that we would follow up more closely, and we just do that in our routine practice. But these are the risk factors to watch out for. Because things like older age is basically just something that is related to the nature of the disease more than anything else.
Besides that, sorry.
Yeah, please.
Yeah, so as you said correctly, that these are the patients we are going to follow up more aggressively and more closely would be the right word, right? We are going to do more perimetries on them and probably treat them, keep their targets a little lower and see for progression a little closer. And then if you see it, then take the appropriate corrective step. So in pseudo exfoliation, which is one of the very important markers, if you see a patient with pseudo exfoliation in one eye, like you showed that cardiologist, but there is no evidence of glaucoma at that point, no high pressure, Discs are absolutely normal. I definitely have such a patient. I kept her on close follow-up for 2 years, and the moment I found her pressure going to 20, I put her on a medication. But her fields are still normal. Do you think that we should treat with that kind of close watch for pseudo exfoliation only? I'm talking about.
Absolutely. I think pseudo exfoliation is one of those things where we don't treat it like an ocular hypertension. In an ocular hypertension, you may be okay with 24, 25. But in a pseudo exfoliation, you may be hiding an IOP of 30 or 35 when you're not seeing the patient. So I think our threshold for treatment is much lower. And that cardiologist was actually on a beta blocker. Then he was being followed up somewhere else for 15 years, and then he came in with that sort of damage.
Ronnie, just to be some practical points for the audience. When would you say the patient has a slow progressor and a fast progressor? That is one. And when you say, okay, just yeah, there's a question that they were asked. So just go ahead with this first question.
Yeah. So when you look at the visual field progression rates, then what happens is that the if you look at large data sets, then the natural progression rate appears to be about 0.5 decibels per year. But that is so when we consider people who are fast progressors when they are progressing at more than 1 decibel per year.
Ronnie, sorry to interrupt you. I just want to, they're asking, is it a mean deviation that you really look at, or the
Yes,
PSD
yes.
that you are really looking at? That
So
is
you're looking at change in MD. So you're looking at a change of more than a change of worse than 1 decibel per year is a fast progressor. A catastrophic progressor is somebody who's progressing at more than 2 decibels per year. So the average clinical patient is usually somewhere around 0.5 decibels per year.
So that's, we are talking about the Humphreys mean
Yes.
deviation. 1
Yes.
decibel per year is fast progressor. Around 0.4, 0.5 is a slow progressor. And the real fast progressor possibly around 1.5 to 2 decibels per year.
Yes, because then
They're going to go and lose their vision very quick time.
yeah, in 5 years you'll lose 10 decibels. That's catastrophic.
Yeah. Any other?
One more point which I wanted to bring out, we are always talking about the biomarkers for fast progressors, but that is we are talking about open angle glaucoma alone. Narrow angle glaucoma by itself, the progression rates usually are much higher than you see in open angle glaucomas. So that is also a point, that treats narrow angles with a different approach than the open angle. So Ronnie, would you agree to that?
No, I agree with you because I mean there is information data that narrow angles do tend to show greater fluctuation than open angle glaucoma. So that's one of the obvious risk factors. And the second is that the spike that they get, they may be exposed to much higher spikes than you get with primary open angle. But and cynical damage obviously reduces outflow, so that becomes a challenge.
Is that you consider not only the mean deviation, would you be really looking at where exactly is the field loss and where exactly is the progression, like the central 10 degrees, or if it is superior or inferior?
Yes. So
Be
obviously,
considering that as well, or you just look at only the MD and then you go with it?
so the thing with rates is that they are based on the MD. But when you look at somebody who's got damage in the extreme periphery, who's progressing a little bit, you're not so concerned. But when you see someone who may not be progressing very much on the MD, but is developing points adjacent to fixation which are getting worse, then you would consider that as significant progression and you would be more aggressive with treatment. So going by the rate alone is fallacious because you have to use both the trend and the event-based algorithms to actually define progression. So anything close to fixation is something that requires aggressive intervention.
Yeah, that's the very important information that we need to kind of pass it on. It is not only the MD, where exactly is the defect and which defect is progressing, that is also equally important. So, Rajul, would you really like to advise people who are the audience today to buy an SLT?
No, buying SLT. So no, then it becomes the different talks of cost effectiveness. But yes, I think SLT is
Basically, I'm just trying to come to that. And also, as we
SLT.
know that at the end of first year, 50% of the patients, they don't come back for follow-up.
So that's why I talk that adherence is an issue, follow-up is an issue. But see, doing SLT, we are not removing that completely because the glaucoma is a chronic disease. The patient has to come for regular follow-up. But after the light study, see, if you had asked me a decade back, and I said very clearly that I would have said medication first, all the patients. But now, after light study, I would say that early POAG, especially if the patient is treatment naive, I would definitely consider SLD as a first option. Buying, I think it depends upon what is your practice, how many open angle glaucoma patients you are seeing. In Mumbai and some big cities, I think they can get the machine on rent also. So that also would be a more cost effective option. But if you have a good number of open angle glaucoma, I think POAG, at least you should offer SLT as a first line. That I'm very sure about it. Especially patient who is early POAG or ocular hypertension. We are not talking about anger closure. So anger closure is a different ball game. Then we have to discuss lots of other things, SLT as a first line. So, but in those patients, I would say SLT definitely should be considered as first line. We
Rajul, just to,
not be
yeah.
blind with the medication in all the patients because medication do have a problem.
So, Rajul, would you do the SLT for reducing the IOP, or in combination to that, would you really look for the blunting of the fluctuations as well in an SLT in comparison to the medications?
So I think all
Because there
bottom
is evidence. Yeah.
counseling is very important at the end. So early POAG patients we can consider SLT instead of medication, and the patients maybe
Rajul, I'm not sure whether you got my
I
question.
got your point about the fluctuation.
Yeah, correct.
I got your point. So I'm just answering in
Right, right.
continuation.
Please.
So, but yes, SLT do the studies do show that IOP fluctuation is less with SLT. But when I'm counseling the patient, I have to tell, especially patient required more medication, that you will be on medication along with the SLT. And yes, I would consider SLT in other patient also. So I used to do and I still do even patient who require 2 3 medication, because if the patient the drug load reduces and IOP fluctuation reduces is a good thing. So SLT I would consider in all spectrum of patients, but I would say that we should do routinely. We can consider routinely all POAG, especially treatment name, because of the better success rate.
Just to be another practical thing. So the question has come saying that which SLT machine that would you prefer? Is the Indian SLT machines are good enough?
I have not
Or
used
is
Indian.
that you just do only the MNCs are better?
I have not used Indian. I any Ronnie, any idea? Uh, George.
Ronnie, George, any other, Manish?
I haven't used, but I've heard from other people who have used it that it's a little less consistent.
So I have used two different company. I forgot the name. One is from L. No, what is the name?
Luminous.
Luminous. Luminous. The machine is good, but it's very delicate. So you required a very high maintenance and the care. And the other one is LX, no?
Yeah,
LX.
LX.
Alex is very sturdy machine. So the luminous,
What,
because
what,
I used luminous for a long time. It's very delicate, and I had joined one hospital, and they had kept the because there was no one to do SLT. They had kept the machine in one lock room, and the machine literally we had to send machine 3 times to the company, change the
okay.
cavity, everything. So luminous is a very delicate machine. This is very good, but if you are willing to take care, luminous is good. Otherwise, Alex is very sturdy. I have
Okay.
used two machines.
So I'll just give you my perspective on, because I've used both the MNCs as well as our Indian machines.
Okay.
Uh, I don't have any financials with any of the Indian machines or the imported ones. Uh, for me, sometimes I used to feel that the Indian machines had worked little better in IOP levels. The long-term follow-ups we have, quite surprisingly, that we don't have to be really biased. The only thing which I have felt the MNCs is the practical application of the gonio is little difficult in the MNC machines in comparison to our local machines. I'm not naming the local machine's name, but then it is very easy to do in the Indian machines.
Yeah.
It's just like our how you do the yaw capsulotomy. So it is pretty easy. And only issue that we have faced in the
But
Indian machine is
I think
that
it
you
is
really may not be able to see the bubble formation,
okay.
which you probably will be able to see much better with your MNC machines. So that is a practical point which I thought I should share with you, because not everybody can afford to buy all the imported machines all the time. The Indian machines are cheaper as a combo, and as well as it is quite efficacious as well.
So is with the YAG and SLT or
Yeah, yeah, correct. Yeah, got SLT. Yeah. So any other points, Manish or others? Because we are running out of time now. Any George, Rajul, and Ronnie, you have any points in any of the three topics? Please add up, and then we'll conclude the session. Have some practical points for our audience? It is very important. We give some take-home messages. Any practical tips? Any more practical tips would you like to say? All right.
I think we have covered very nicely all the
Yeah.
topics.
So thank you so much, and we will soon post all the 7 days program in your. If you are a member, you will be receiving it in your emails sooner. I'm not promising you tomorrow itself, but you will receive all the 7 days of the webinars. Thank you so much, all the speakers, for all these 7 days program. The reason why we wanted to have this 7 days masterclass program is just very simple. Though there were many areas that people were saying that we should do more of an awareness campaigning for the public. It is well understood. We all have to do that. But teaching to all our friends and colleagues is so important that we manage the glaucoma in a better way on what we are doing currently. So thank you so much, every one of you, for your wonderful talks and very important tips for the audience. So we'll see you soon in the next program. Thank you all and good night.
Good night.
Thank you, everyone, and really excellent talks. And I'm sure that this will
Thank
be
you, sir. Thank you.
followed
Thank
by
you.
a lot of people as when it becomes available online. Thank you. Thank you very
Thank
much.
you.
Good night.
Good night.
And
Good night.
this will be available in our GSI website. All of you can access anytime. All the 7 days program will be available in the GSI website as well.